finally introduce Andreas Makris, who is leading breast cancer research at the Mount Vernon Cancer Center in the UK. He is a true European, and I'm not going to make any comments on the Brexit story, and I think he won't either. But he's going to tell us something very interesting, because for many of us in continental Europe, let's put it that way, NICE is a role model for the better or worse of how a healthcare system makes its decision. And I think with today's subject, you have some interesting news to tell us. Andreas, thanks for being here.
Thank you, Michael. And I thank you all for choosing to forego your 5-course lunch outside for a lunch in a packet during this lunch period. I'd like to thank the NanoString for inviting me to come to this beautiful city of Vienna, and for a couple of days forego all the arguments in London about Brexit. And that's the last time I mentioned it. So, can we change the... So I'll be discussing Prosigna in the UK, particularly NICE recommendations, and also touch on the OPTIMA trial that I'm involved in the UK. This is my financial disclosures. So I'll be discussing first was how do you determine prognosis in early breast cancer, though this audience is clearly familiar with that, about Prosigna availability in the UK and the NICE guidance, about some of the data with regards to the genomic tests head-to-head within the TransAttack study. I'll talk about the prospective OPTIMA study in node-positive patients, touch on some other prospective studies, and then reach my own conclusions at the end. So as a result of the Oxford overviews that were done in the 1980s and 90s, it became apparent that there was benefit of adjuvant chemotherapy for all patients, although the absolute benefits were small, but there was this similar relative reductions for all patients. And the 2000 NIH Consensus Conference came up with the statement that adjuvant chemotherapy should be recommended to most women with primary breast cancers larger than 1 centimeter in diameter, regardless of nodal status, menopause, or hormone receptor status. And this led to a golden age of overtreatment that lasted for about 15 years until the advent of the genomic assays. So the determining prognosis, we're all familiar with conventional factors like the tumor size, nodal status, grade, added to those the factors by IHC. And the first attempt at putting these together to give a prognosis for patients was the first generation of integrated indices, such as the Nottingham Prognostic Index, the adjuvant line, which was widely used until and developed by Peter Rafton in San Antonio, but is no longer available. And in the UK, the PREDICT program developed by Cambridge is widely used, and I understand that is also used outside the UK now, and hundreds of thousands of patients' predictions have been done using PREDICT. And then the new kids on the block, of course, are the genomic assays, and there are multiple of those. And we'll discuss some of these. Bent has already discussed this about based on the overview analysis, that clearly the relative risks are the same for all patients based on conventional factors, but the absolute benefit is small for patients with a distant recurrence of less than 10%. And this was a cutoff that was used by many groups in the development of their genomic assays. So the Prosigna has been looked at and evaluated by multiple guideline-producing groups, and including St. Gallen, NCCN, AGO, ESMO guidelines, and they all support the use of Prosigna as well as other genomic assays, particularly for the patients with node-negative disease, ER-positive, HER2-negative. The development of Prosigna is based on a lot of data, and we do not need to. Some of it has been discussed already. Clearly, the prognostic ability of this test has been shown in multiple studies, and you've heard some from the Danish group, and there's also data from neoadjuvant studies which show the prediction of response to chemotherapy based on that. Clinical utility, there is a great study from Norway, which is a cohort study capturing the majority of the population over a 3-year period, showing the value of the test there. There have been multiple decision impact studies which are really important because these really show that when you receive a result of a Prosigna test, will you then change your treatment based on this? And clearly this has been the case and in multiple impact studies. And these have been done across multiple healthcare systems, and it's not just in one or two systems. And then the UK prospective trial, OPTIMA, looking at the node-positive population. Now, the NICE, first of all, NICE was set up 10, 15 years ago with the aim of helping the UK NHS to make decisions, cost-effective decisions about treatments. And so that treatments which are cost-effective, they will be widely available, and treatments which are not effective, they will not be used. When NICE first started evaluating treatments, they were very restrictive in what they were producing as guidance, and because there was not much money put into healthcare. But as the NICE has matured, more money has gone into healthcare, the decisions they're reaching are more in line with what clinicians treating those diseases would want. So the NICE guidance for tumor profiling in early breast cancer, looking at the ER-positive, HER2-negative population, it took about a year to develop. And what they have recommended is that Prosigna, EndoPredict, and Oncotype DX to be used in the ER-positive, HER2-negative, node-negative population, but this to be done in an intermediate risk category for distant recurrence based on a validated tool. And in the UK, what is used is the NPI or the PREDICT program. And the test is been developed, recommended for making a decision whether to use adjuvant chemotherapy in addition to the endocrine therapy. And the companies all agreed that they will provide results afterwards to the data that on a national basis that has been collected. Importantly, NICE also agreed to these tests in patients with micrometastases, and given that they have been conservative in their guidance in the past, this was important because they said that many of the patients with micrometastases in the older trials that went on to inform the genomic assays, they would have been called node negative, and because some preceded the era of sentinel node biopsy. They did not recommend MammaPrint due to lack of cost effectiveness, and they did not recommend IHC4 due to issue of analytical validity and reproducibility. So the document, the NICE document, is a large document, and I'm just picking up one of the analyses that they did, the NICE group, and it is table 124. So that in itself tells you how big a document it is. And is looking at the 10-year distant recurrence based on the four of the tests, Oncotype, Prosigna, IHC4, and EndoPredict. And what we're looking at here, in what I've highlighted, first of all, the node-negative population, and based on an MPI more than 3.4. This is the cutoff point at which NICE recommended the assays in the UK population. And if we're looking at with Prosigna, in the low-risk population by Prosigna, there's a 10-year recurrence of 7.7%, which is numerically half of what it is for the EndoPredict and Oncotype. And similarly, for the high-risk group, the Prosigna picks out a greater number than the others, but the difference is not as big as with the low-risk group. So as regards direct comparisons of these assays, the best data comes from that presented by Ivana Sestak and now published in JAMA. And this is looking at the TransAttack trial. ATTACK trial started about 15 years ago, comparing tamoxifen with anastrozole, and that showed a superiority for anastrozole, and that led us to the widespread use of anastrozole in postmenopausal women with early breast cancer. And in this study, they went back and they compared a number of platforms, including Prosigna, Oncotype, EndoPredict, BCI, as well as IHC4. And what the patients within the study, obviously they were all postmenopausal. The majority were grade 2 and 3, and there was data going up to 10 years. So what this study has shown is that if you're starting off with the nodal status, grade, tumor size, age, treatment, CTS score, which is given, what more information do you get by adding the genomic assays or IHC4? And all of them, looking at the node-negative population, all of them gave you more information. But if you compare the extra information that is given, the ROR Prosigna score gave the most extra information. In node positive, similarly, there was extra information, but it was, although significant, it was weaker than for node negative disease. Now, looking at the TransAttack data, and this is from Ivana Sestak's presentation at San Antonio from 2 years ago. And if we're looking at the patients, first of all, on the node-negative patients, what you can see is that with the low score by Prosigna is picking up a smaller number of patients recurring at 10 years, 3% as opposed to 6% by the Oncotype. And similarly for the looking at distant recurrence at 10 years for node-positive populations. And this has now been published, as I say, in JAMA, and it's showing the extra benefit of using genomic signatures and in addition to conventional factors based on a population of patients who received endocrine therapy and largely did not receive chemotherapy. And the ROR Prosigna gave the most prognostic information within that subset. So if we go on to the OPTIMA trial, as we know, what we discussed is that clearly there is a good evidence for the wide use of these signatures in node-negative populations. But what we wanted to do is to look at the node-positive population and how well do these signatures perform in the node-positive population. We started off with a pilot study with 400 patients, and this was required for us by the sponsors of the study in order to help us to choose which is the best assay for us to take forward. And they also wanted us to show that in a node-positive population, patients and physicians are prepared to accept the randomization results. So what we in the pilot study, we randomized patients on the basis of Oncotype, but we did 6 assays, and what we were able to show is that it was clearly acceptable to patients to have the randomization based on a genomic assay. But based on the analysis then we did of multiple assays, we chose to go with Prosigna for the main study based on the economic modeling that we had done. And there's an email address there for the OPTIMA, trial office in Warwick, and anybody who's interested in your own countries to take part, please contact either the OPTIMA office in Warwick, or please talk to me afterwards, or if you want, email me afterwards. So the OPTIMA main trial, this is the design, and the patients are randomized between the control arm, which is chemotherapy plus endocrine therapy, while in the control arm, patients have Prosigna, high score, you get chemotherapy, low score, you do not get chemotherapy, get endocrine therapy. It's based on a non-inferiority of 3% difference, and we want a 4,500 patient population with a recruitment period of 4 years. And so far, it's open in 93 centers in the UK and 1 in Norway. More centers are opening in Norway, and we have a total of 1,348 patients already. And within the pilot study, all of those 412 patients have been followed for at least 5 years. And so for completeness, the other study that you will be familiar with, that for node-positive patients, is the completed American study, a responder, where patients, the decision was made on the basis of oncotype. The difference between the OPTIMA and responder is that in responder, it was up to 3 nodes positive, while in the OPTIMA, we go up to 9 nodes positive. Additionally, in the premenopausal women, for patients in responder, the choice of endocrine therapy was based on a choice of clinician. In OPTIMA, we mandated for everybody to have ovarian ablation so that we don't have the confounding effect of chemotherapy causing ovarian suppression in the premenopausal patients. And then for also completeness, you've heard already this morning from Boon Chua, the study from Australia, NZ1601, where Prosigna is used in order to guide the decision for use of radiotherapy in patients with early breast cancer. So to conclude, the NICE have recommended Prosigna as well as Oncotype and EndoPredict for node-negative patients at intermediate risk and as a cost-effective test, but they also importantly included patients with micrometastases. We feel that the design of OPTIMA is a gold standard approach for the test clinical utility and effectiveness of a test. We chose to go with Prosigna within the OPTIMA main trial. We feel that OPTIMA will provide level 1A evidence for the benefit of test-directed treatment. And the OPTIMA population is a high-risk patient, primarily node 1 and node 2, and is more likely to generate convincing evidence for the clinical utility of an assay where it is most needed, those patients with the highest risk of recurrence. Thank you.
Thank you, Andreas, and thanks to all the faculty for the discipline that actually enabled us to catch up with all the time after the late start. Maybe a quick question, Andreas. Now there are 3 tests available in the UK. How are they used, or how would you use them?
I mean, we're not usually in a situation we'll have options and choices in the UK, but it's like, what do we have an expression in London about London buses? You wait for one and then 10 come at the same time. So we have 3, and every clinician is able to choose any one of the 3. And they will make different arrangements, different clinicians and centers. For Prosigna, it will be done in the UK. It will not be sent outside the UK. And a number of centers in the UK, laboratories has been set up in order to provide the test.
Okay. Microphone 1. Dan Hayes.
Hi, Dan.
Can we have energy on microphone 1?
Good. I'm Dan Hayes, University of Michigan. I just want to make a point to everybody. There are now several assays that roughly do the same thing that are approved in many countries. I believe that it's very important that you not order 2 assays on the same patient. I would strongly urge you to pick one you like and stick with that. And because if you start ordering 2 tests on the same patient, I guarantee you'll have patients with 2 different results. And don't call me if you do, because I'm not going to know what to do either. So great talk, but just use one assay that you like and stick with it.
Yeah. Thanks, Sad, for that. If somebody in the UK said to me that if we do 2 tests on the same patient, you get different results, then you have to do a 3rd one and choose for 2 instead of 1. I wouldn't advocate that, and I agree that we stick to 1 test per patient. Yeah.
Okay, and really quick, what's the turnaround time for
the for Prosigna, it's currently being set up in the UK, but within the trial, we're getting turnaround about a week for most patients and 2 weeks the most.
Okay, so thank you very much.